Welcome to MedStudious. Today, we are reverse engineering the ultimate biological engine, the human heart. At the organism scale, this organ functions not merely as a simple pump, but as a dual-chambered, highly synchronized pressure vessel. The right side of the heart, driven by the right ventricle, operates as the pulmonary pump, propelling deoxygenated blood through a low-resistance network to the lungs. Concurrently, the left ventricle acts as the high-pressure systemic pump, driving oxygenated blood throughout the entire systemic circulation. This entire macrostructure relies on a flawless coordination of inflows via the superior vena cava and outflows through the massive aortic arch. Understanding this complex machine requires us to strip away the macroscopic anatomy and dive deep into its structural and physiological blueprint, moving from cell mechanics and molecular engines up to systemic function, and ultimately, what happens during catastrophic failure. Let's begin our journey down to the microscopic foundations.
To truly understand how this pump operates, we must trace its origins back to embryological development. The human body is built upon four fundamental cellular pillars: epithelial tissue, connective tissue, nervous tissue, and muscle tissue. Each possesses a highly specialized evolutionary role. However, the heart represents a masterclass in tissue specialization. Originating from the early embryonic mesoderm, cells undergo precise differentiation to form the primitive heart tube. Within this developing structure, muscle tissue becomes uniquely optimized. Unlike epithelial tissue designed for barriers or connective tissue meant for structural support, this specific lineage is radically adapted to regulate, generate, and sustain continuous contractility. Every cell within this lineage focuses entirely on the efficient generation of mechanical force. This primitive blueprint lays down the structural framework for what will eventually become an uninterrupted, lifelong mechanical cycle of contraction and relaxation.
Evolution has produced three distinct contractile architectures within the human body: smooth muscle, skeletal muscle, and cardiac muscle. Smooth muscle, found embedded within the walls of our organs and vascular channels, operates completely under involuntary autonomic control, lacking visible striations. On the opposite end of the spectrum, skeletal muscle is engineered for voluntary, conscious movement, featuring highly organized, elongated, multinucleated fibers firmly attached to our bony skeleton. Cardiac muscle, however, represents a fascinating structural hybrid. It is found exclusively within the walls of the heart. Like skeletal muscle, it exhibits dense, microscopic striations due to its highly organized internal machinery. Yet, like smooth muscle, its operation is entirely involuntary, governed smoothly by the autonomic nervous system. Structurally, instead of long multinucleated fibers, cardiac tissue forms short mono or binucleated cells arranged in intricate, branching, chain-like arrays.
Let's isolate the individual workhorse of this system, the cardiomyocyte. This cell is the primary contractile unit of the heart wall. Geometrically, a healthy adult cardiomyocyte measures approximately 80 to 100 micrometers in length and maintains a narrow diameter of roughly 15 micrometers. This narrow profile is absolutely critical, as it ensures rapid diffusion of ions and oxygen across the cell membrane. Unlike skeletal muscle cells, where multiple nuclei are pushed to the peripheral margins, the cardiomyocyte typically features one or two centrally located nuclei. Its defining physical characteristic, however, is its distinctly branched architecture. These cells do not lie in simple parallel lines. They split and branch out to connect with multiple neighbors. This specialized, highly branched network becomes uniquely altered in clinical pathology. In conditions like hypertrophic cardiomyopathy, the heart muscle becomes abnormally enlarged, and these branch points show marked structural disarray under microscopic examination.
If we look deep inside the cardiomyocyte, we discover the molecular engine itself, the sarcomere. The structural organization here resembles a highly efficient mechanical piston mechanism. Each sarcomere is strictly bounded by structural borders known as Z-discs. Extending inward from these Z discs are thin filaments composed of the protein actin. Alternating between these thin strands are thick filaments composed of the motor protein myosin, localized in the central A band. The lighter regions, containing only thin filaments, form the I band, while the central zone, containing only thick filaments, forms the H zone. Mechanical force is generated through the sliding interaction of these actin and myosin filaments. Using energy from ATP, myosin heads repeatedly bind, pull, and release actin filaments, drawing the Z discs closer together. This repeating molecular alignment across the entire length of the cell creates a beautiful optical phenomenon under the light microscope, the alternating light and dark striations characteristic of healthy, functional cardiac muscle tissue.
Because cardiac muscle cells are individual units, the heart must solve a massive engineering challenge. How do billions of independent cells pull together at exactly the same moment without tearing themselves apart? The answer lies within the intercalated discs, which provide complete mechanical and electrical synchronization. Think of these discs as containing two distinct systems, the zipper and the wire. The mechanical zipper consists of desmosomes. These are heavy-duty intercellular junctions, providing powerful adhesive bonds that lock adjacent cell membranes together, preventing the cells from pulling apart under the immense mechanical stress of continuous contractions. The electrical wire consists of gap junctions. These are highly conductive transmembrane channels that allow rapid, direct ionic continuity between cells. By allowing ions to flood instantly from one cell to the next, gap junctions bypass standard chemical signaling, transforming billions of individual cells into a single, flawlessly coordinated functional organ, known physiologically as a functional syncytium.
Having mastered the cellular components, we can now assemble them into the three-layered structural chassis that forms the wall of the heart. The outermost layer is the epicardium, a protective sheet fused directly to the external surface of the underlying muscle tissue. Beneath this lies the primary functional powerhouse, the myocardium. This middle layer is by far the thickest part of the heart wall, comprised of dense bundles of cardiomyocytes wrapped carefully in an extracellular connective tissue matrix known as the paramecium. The myocardium provides the raw structural scaffolding and contractile power responsible for the heart's relentless pumping action. Finally, lining the internal chambers of the heart is the endocardium. This thin, smooth internal layer is composed of a simple squamous endothelium continuous with the lining of the great blood vessels, ensuring that blood moving through the chambers encounters minimal friction as it flows.
Let's focus closer on the outermost boundary, the epicardium, and its relationship with the surrounding pericardial system. The heart does not sit loosely in the chest. It is housed inside a specialized, multi-layered protective sac. The outer boundary is a tough, inelastic sheet called the fibrous pericardium. Lining the interior of this tough sac is the double-layered serous pericardium, divided cleanly into a parietal layer and a visceral layer. The parietal layer adheres firmly to the fibrous outer sac, while the visceral layer folds inward to coat the surface of the heart directly, forming the epicardium. Between these two delicate serous layers sits the narrow pericardial cavity, filled with a specialized lubricating fluid. This fluid establishes a virtually frictionless environment, allowing the heart to beat violently and expand rapidly without suffering tissue wear or raw friction damage. Additionally, this layer contains variable amounts of epicardial adipose tissue, which provides crucial shock absorption and serves as an immediate local energy reserve for the hard-working muscle below.
The structural architecture of the myocardium is not uniform. Its thickness changes dramatically based on the specific workload required. When we examine a cross-section of the lower heart chambers, we see that the ventricular myocardium thickness directly dictates its physical pumping range and pressure capabilities. The right ventricle features a relatively thin myocardial wall. This is a deliberate engineering adaptation.
Its sole responsibility is to pump deoxygenated blood into the nearby lungs via a short, highly compliant, low-pressure loop. In stark contrast, the left ventricular myocardium is engineered to be 2 to 3 times thicker than the right. The left ventricle is the systemic workhorse, built to generate massive, high-pressure output to propel blood out into the high-resistance network of the entire human body. This extreme wall thickness is a pure physiological adaptation to resistance, ensuring that even the most distant capillary beds in the feet and brain receive steady, pressurized blood flow.
To make this thick, muscular pump work efficiently, the heart requires an internal electrical timing network, the subendocardial conduction system. Muscle contraction cannot happen haphazardly. The electrical wave must travel through the heart along highly specific pathways. This network relies on specialized cardiac cells called Purkinje fibers. Histologically, Purkinje fibers are significantly larger than standard cardiomyocytes, packed with abundant glycogen and mitochondria, and lacking standard contractile myofibrils. Positioned within the subendocardial connective tissue layer, these specialized cells form an electrical highway linking the atrioventricular bundle of His directly to the ventricular myocardium. Their primary engineering function is synchronized conduction. They transfer electrical action potentials rapidly and efficiently from the internal endocardial layers deep out into the thick myocardium. This fast electrical spread triggers a unified, highly coordinated, and powerful contraction of the ventricles, squeezing blood from the apex of the heart upward into the great exit arteries.
If we step inside the hollow chambers of the ventricles, the walls are not smooth. They are lined with an intricate web of muscular ridges and columns known as the trabeculae carneae. These deep muscular columns serve a vital dual purpose as an internal anchoring system. First, they disrupt smooth fluid flow, preventing highly turbulent blood from creating damaging suction forces inside the chamber during rapid emptying. Second, they work in close structural coordination with the papillary muscles to regulate tension and pressure control. During the peak force of ventricular contraction, these muscular anchors pull firmly on the chordae tendineae, the tough thread-like cords attached directly to the leaflets of the tricuspid and bicuspid valves. This structural tension prevents the delicate heart valves from prolapsing or turning inside out under the immense intraventricular pressures generated, effectively neutralizing backflow and ensuring blood moves forward through the correct exit tracts.
Because the heart is a high-performance engine that never rests, it has massive metabolic demands. It cannot simply absorb oxygen from the blood moving through its internal chambers. It requires its own dedicated external fuel lines. This is the vascular coronary system. The supply side begins at the base of the aorta, where the main left and right coronary arteries branch off. These large vessels dive deep into the tissue, branching further into microscopic intramuscular arterioles that penetrate straight into the core of the active myocardium. These arterioles feed a dense network of intramuscular capillaries that weave around every single cardiomyocyte, delivering a constant supply of oxygen and key nutrients. Once gas exchange is complete, the return side of the system takes over. Deoxygenated blood is collected by small venules, which empty into the large cardiac veins. This spent blood is routed back into the right atrium via the coronary sinus, ready to re-enter the pulmonary loop for reoxygenation.
What happens when these crucial fuel lines fail? This brings us to a critical clinical emergency, the ischemic cascade, culminating in a myocardial infarction, commonly known as a heart attack. The cascade begins when a coronary artery experiences critical stenosis, usually due to the sudden rupture of an atherosclerotic plaque or a blood clot. This block completely cuts off downstream blood flow, starving the highly metabolic sarcomeres of critical oxygen. Without oxygen, cellular respiration stops instantly. ATP levels plunge, and the mechanical sliding filament engine grinds to a halt, leading to tissue death and catastrophic cell necrosis.
Clinically, this catastrophic failure presents with definitive systemic symptoms: intense, crushing chest pain that often radiates down the left arm or up into the jaw, profound shortness of breath as the pump fails, extreme fatigue, and a cold, clammy sweat triggered by a massive surge of the sympathetic nervous system.
Managing a structural failure of this magnitude requires a definitive two-phase clinical protocol. Phase 1 focuses on acute hospital stabilization to halt ongoing tissue death and restore immediate blood flow. Emergency teams immediately administer oxygen alongside a precise pharmacological cocktail: aspirin to inhibit further platelet clotting, nitroglycerin to rapidly dilate ischemic coronary blood vessels, and beta blockers to lower the heart's workload and oxygen demand. In severe cases of multi-vessel blockages, emergency surgical intervention via a coronary artery bypass graft is performed to physically reroute blood flow. Once stable, the patient enters Phase 2, long-term biological maintenance and risk control. This phase involves aggressive, permanent lifestyle and pharmacological changes designed to stabilize biomarkers and prevent secondary events. Hyperlipidemia is managed via daily statins. Blood pressure and diabetes are tightly regulated with targeted drugs, and patients must commit to rigorous cardiovascular exercise and smoking cessation to protect their remaining myocardial tissue.